The IOMS is pleased to welcome you to today's webinar, Distraction versus Advancement in Orthognathic Surgery, Osteogenesis in the Personalized Medicine Era, presented by Professor Rajid Rana and Dr. Albertito Radad. Please note, today's session is being recorded and all participants will be muted during the presentation. Personal audio or visual recording of this program is prohibited. If at any time you experience technical issues, utilize the chat feature within Zoom to contact staff directly. This chat bar will also be used for the Q&A portion of the program. When submitting a question, please specify your name and country. Today's session will last 60 minutes, with question and answer following the presentation. You may submit a question at any time. It is now my honor to turn the webinar over to our moderator, Professor Nardi Kassab.
Good afternoon, everyone. My name is Professor Nardi Kassab, and I am delighted and excited to open the first IOMS webinar of the Controversies webinar series. I want to thank all of the great people of IOMS for this opportunity to expand our academic and educational doing. I want to thank especially Dr. Alejandro Martinez for his leadership and support. I want to thank the Education Committee of IOMS and especially the chairman of the committee, Dr. Gali Gali, for all his efforts to make such a project available. I want to thank the Webinars Committee and her chairman, Professor Rana, who is here with us. I want to thank Mr. Lacey McLeod from IOMS for all the coordination and planning, and Xander for the technical support. Without Lacey and Xander and the IOMS team, all of these activities could not be done. Last, I would like to invite you to two other activities of the IOMS. I want to remind the ICOMS meeting, which will take between June 8 to 11, 2023 in Vancouver, at the Vancouver Convention Center. We have 23 master classes, 40 symposium, 6 plenary sessions, 2 presidential lectures, and 1 trainees lecture. The second event is the 105th AOMS annual meeting in San Diego, which is held between September 18 to 25, 2023, where the International Association will hold the Global Health Cafe. We will have roundtables and cases will be discussed. This is an event that will be an hour and a half. Okay, and now for our webinar. Today's topic will be orthognathic surgery versus distraction osteogenesis in the personalized medicine era. We live in an exciting technological era, and it's always important to check ourselves and to the paradigms of our work. My partners for this webinar will be Professor Majid Rana and Dr. Alberto Haddad. Majid and Alberto, as you know, are two excellent surgeons and teachers and are prominent speakers that I'm sure we will enjoy their experience, knowledge, and skills. We'll discuss this topic together through presentations and a live discussion. So let me present to you our speakers for this webinar. Professor Majid Rana is a professor for oral and maxillofacial surgery at the Heinrich Heine University of Düsseldorf, specialized in personalized craniomaxillofacial reconstruction, holds several degrees, including MD, DDS, MBA, education officer at the IOMS, education officer at the AOCMF ESA board, and has more than 100 international publications. Our second speaker is Dr. Alberto Haddad, is consultant at Ramon E. Cajal and Puerta de Hierro University Hospitals in Madrid, Spain, specialized in craniofacial trauma and orthognathic surgery, and also microsurgery and reconstructive surgery, fellow of the European Board of Oral and Maxillofacial Surgeons, and member of the IOMS Education Committee. The first presentation will be by Professor Majid Rana. Professor Rana will give us an overview and present some cases of destruction. Professor Rana, please.
So many thanks, Nadi, for this nice introduction. And again, thanks for joining us, supporting us, and coming up with this idea to talk controversial on that. So dear participants, orthognathic surgery, that actually the theme for today. And this will be my content to talk a little bit on conventional planning, talk on virtual planning, orthognathic surgery. But my part today will be to talk with you about distraction osteogenesis and debate later on mid-phase hypoplasia and what I prefer in my daily clinical routine. So again, I want to thank my teacher, that's Peter Brachvogel, and what he always taught me was the best facial cosmetic surgery is actually orthognathic surgery. And therefore, all my knowledge and things like that, I have it from my teacher. So orthognathic surgery, conventional planning, for those who deal with that, you remember in your clinic, it's always in the hand of the most experienced guy. And he's like cooking his magic soup. And you don't really understand what actually is he doing with model surgery. And the formula how to plan and do model surgery is always kept like the Coca-Cola formula in Atlanta. And you're all familiar with that, the way of conventional planning using model surgery and cephalometric analysis. And we should not forget that these conventional plannings have advantages also. And the advantages are, this is a standardized and established procedure, simple technique with a very low cost, simple interdisciplinary communication, but you have less information about anatomical structures. It's really difficult to analyze the complex movement of mandibular, maxillary alignments and the advancements, and the aesthetical outcome and appearance still need a challenge. I want to show you that I still got a lot of influence in my teaching about Niels Gehrig, Bert Hammer, Alexander Schramm, where I went off, and Wolfgang Carter in Bad Homburg, where I worked 2 years. And of course, Ed Ellis, who influenced me a lot in the way of thinking and performing. But what is common at all of them is 3D analyzing. So in our university, not a single case in orthognathic surgical disease is operating without having a 3D analyzing. Because we need it, we can only treat what we are able to see. In my concept, there are always functional aesthetical aspects, and always is the challenge to reduce complication. And doesn't matter what we do, we need to consider, yes, the digital planning has advantages. We can visualize anatomical critical structure. We can align to the complex maxillary mandibular movements. And we have something like soft tissue simulation. Will I show it to my patient? No. But in teaching hospitals, it's very nice and important to understand the movements and what we have. And if we have advantages, we have disadvantages also. And yes, 3D analyzing, you cannot do without radiation exposure. And we need to inform our patient. We have cone beam CTs. We do sometimes intraoperative imaging, and that you need to have. The companies don't give us the hardware for free. You need to have infrastructure. You need to have some manpower and some know-how. Considering that, the typical steps in planning are actually all the same. We define ideal occlusion, we plan an ideal facial profile, we define the ideal chin position, and we consider something like overcorrection. Again, in terms of watching aesthetic and functional outcome. And at the end, what we want to have is a long-lasting clinical result, especially if we deal with asymmetries on that. Now, again, on my topic, distraction. What is important and why maybe it's important? With this picture, I want to show you, yes, we need to consider soft tissue. And that's important, especially if we are talking on large advancements we are thinking on. And you can see one of the cases, a young lady with a maxillary hypoplasia, and you can see dentally compensated. And normally our way will be to totally decompensate and work further on. But in this case, she wanted to undergo and wanted to marry. So the way was, and that's back 2014, one of the first cases of digital planning where I printed out a occlusion splint and did like a wafer for positioning and cutting guides. And that was a situation intraoperatively. You can see the advancement of the maxilla, and that's her later on. So the mandible is just corrected in the midline, and you can see we have a large advancement of the maxilla and giving her a profile and considering the aspects. What about these cases? You can see a vertical excess and already had a surgical assisted rapid maxillary expansion, now frontal open bite, again, large advancement to the vertical part and advancement front, again, the same way, considering patient-specific implant, planning the position of the screws. And you can see here the preoperative simulation that we are using all the fancy tools to transfer the information into the OR and see where are the boundaries, how much can be advanced or how much can we verticalize with that. And then you transfer this simulation in the OR, perform the surgery, and you see the post-op result. And now the first time you have a tool where you can control your planning with an intraoperative situation like here with a cone beam CT. Once you go back, then you see, especially in the large advancement of the midface, yes, at the picture below, these are sometimes problems, what we suffer, you can see it here in the picture, where we still have to see that the bony quality is not there. So again, we analyze all these tools and figure out and says, yes, using patient-specific implant for orthognathic surgical treatment allows us a very accurate result. So that's this lady before and after surgery, and you can see her in the profile before and after surgery. Again, asymmetries. In these cases, because mainly they are class 3, these are cases when we have extremely maxillary deficiency. And again, in these cases, we need always to question, do we advance with bone augmentation and things like that, large defects? Or do we consider something like a distraction, what can be there? So again, in these cases, I try to consider class 3 deformities in horizontal and vertical. Or by vertical cases, I operate 100% bimaxillary, and to considering especially in asymmetries, a bimaxillary treatment. My teaching is that a long-term stability you reach in moderate corrections in Bowles' jaw, but the mandibulary midline correction, I hardly do a mandible setback in Caucasian people. So therefore, if I have a situation like that, now you can see if the advancement is more than 7 millimeters, I don't do advancement and go more for a distraction. So my clear statement for today for this webinar is I go for a maxillary advancement up to 7 millimeters rather than mandibulary setback. So midface distraction, of course, you know how it goes. It's actually a simple procedure. We just do a look for one. You can do it in multiple pieces. But always the question is, what kind of vector are we using? How much can be advanced? Do we have an expansion, or are we only considering vertical parts? So up to this, clinically, it's not a big deal to perform. I want to show you a 26 years old patient, and you can see a collapsed maxilla. You can see the fold, the superior lip and the nasal tip. And of course, here, the challenge will be to do an anterior distraction osteogenesis to wait that you have a callus and advance the callus according to that. And here you can see that's the way intraoperatively you really need to stabilize everything totally and then bring up the distractor devices and be sure that you have a reach out of that. And then, yes, you bring them up, especially in cases where I have sleep apnea and I need to do more than 7 millimeter and I want to expand and have a more posterior airway space. I go for this, and you can see here him before and after surgery. And important is to have a good occlusion and long-term stability. Another case, you can see class 3, again, maxillary hypoplasia with microgenia and of course dental loss. And yes, again, the same way. Here you can debate, do you need, because we are something around 7 millimeters, we are around something like 5 or 6. But here again, the way of doing a monoblock distraction on the mandible and doing a distraction. And you can see here the co-op and the way performing the surgery step by step, and here the situation directly, postoperatively, and that's her directly after the operation performing the orthognathic surgical way. And here you can see that something like a little bit overcorrection you need to do to close later on the dental bite and to have the situation totally coming there. So again, when are the cases where I don't do distraction osteogenesis? Especially, I think that's a case we can debate later on, where you can decide if you want to go or not. Because almost the disadvantage is you need to play with the callus, perform the callus, and need to solve later on the problem doing another surgery. We are not debating on syndromic cases like Treacher-Collin. Yes, these cases, I think, in this group will be clear. These cases we cannot solve other way. So we perform, again, 3D planning, plan the distraction, simulate it, like here the mandible, and then, of course, after planning of these procedures, we just do the surgery, and after the surgery, you can just see the floating bone concept, and that's her directly after mandible advancement, and later on giving some projection to the zygoma. And again, monoblock distraction in mid phases, a Goldenhaar case. Again, I would say not a case to debate. Again, the same procedure. And sorry for disruption. Unfortunately, this is not covering up, but that's the situation. I show you that was the plan, a monoblock distraction, performing a one and distraction and doing the surgery later on. This is how you can put wire to put a rotational plan, distract that. And this is the patient before surgery, after the monoblock distraction, post-op result. And here you can see in long-term follow-up, the situation coming in from left to right on this way. So what about cases where we have traumatic injuries or things like that? Especially in these cases where we are suffering some traumatic problems, we can deal with that. But again, in extreme, here cleft lip and palate, all these cases, I think, are all clear that we have a consensus that here we need to do a LeFort-3 destruction, perform the advancement, bringing the whole part forward and to bring them there, align them there. So now what about cases like this? So here you can see a condylar resorption after infect of the condyle she had in the childhood and really limited mouth opening. And if you look to the size of the mandible on the right side and the size of the normal mandible of a grown up on the left side, you can see that it's not only the condyle, even it's hypoplastic. And again, yes, virtual tools helps us using cutting guides. That's nothing new. You all know that. And now performing the surgery, bringing in the first step, the mandible forward, putting together. And the advantage with all of these tools are that you can nicely play around and plan according to the roots, to the nerves, where all the way is. And then you just go for the surgery. Here you can see the colors, which is there. You can perform, and you can again double check in the planning. Yes, the nerve is far away from the insertion, from the points. And of course, then you later on remove the distractors, perform a bimaxillary surgery, perform a gynecoloplasty to bringing her to that. Now I want to conclude, and yes, so 2 minutes still left to conclude and say that yes, we need to consider functional and aesthetic aspects. We need to think about nerve preservation to minimize the risk. We need to think about the cost effectiveness way, because many things what I show you are not paid by insurance companies, and you need to have some know-how, some tools to deal with that. We should not overstress virtual possibilities, because what works in front of the computer does not automatically means that it works directly in real patient also. And we need to keep functional outcome in mind. Why is the patient coming up to us? Are we going to deal with the occlusion? We don't do any financial compromises if it's coming to asymmetric and cleft patient. And with this, you know, everybody has a dream. And I have a dream also to maybe one time operate one of my favorite or the favorite football player. Here you can see the simulation. Yes, it's a time of digital planning, but what we see depends mainly on what we look for. Thank you very much for your nice attention.
Jid, thank you very much. That was amazing. In 20 minutes to tell everything. Can I still keep you for a few questions, or you need to?
Yes, of course, of course.
First, I would like to ask you, I want to enter into small problems. What do you do with the nose when you do these big advancements? Because that's a big problem, I mean, and I don't know what you do for it.
So many thanks for this. Again, the problem is if we consider with a large advancement, and we have the spina, we have the lip length, and all that part. So in these cases, I do like a Y osteotomy to keep the spina at that place and reattach a little bit. I normally go even with the approach with a double VY closure to give a little bit more lip enhancement. And anyhow, if I put an advancement much, I still look on the vertical dimension and see, is it possible that I can, instead of a complete advancement, if I can play a little bit on the pitch, if I can play a little bit on the pitch, still then I can reach a little bit less. So again, the big major problem, what I see in advancement is, and that's why I don't do it more than 7 millimeter, is like later on the danger in relapses or the frontal open bite. So therefore, if I do an advancement like this, I properly be sure that I put some bone in it, that like a patient, what I show you where I didn't put it and then realized later on. So I learned it the hard way. And yes, for the nose, anyhow, if you advance, the nose will be like broken later on, but that would be a challenge in a secondary approach, because in Germany, we take all the plates out and I have access to the patient easily. And then we can do the osteotomy of the nose and that.
My second question, I don't know, let me, when I cannot keep you anymore, is how do you decide between LF4, 2, and 3?
Oh, very nice. So depends on the problem what I had. If I have the problem in let's say, syndromic cases like a Crouzon, things like that, and I need to look on the infraorbital region in this area, all these cases are considered to be and do like in LeFort-3. I have never done in my life a LeFort-2, never, because I think there are other possibilities to deal with that. So in these cases, I hardly go for a zygoma advancement or malarplasty or things like that and perform a LeFort-1. And I think I achieve the same results.
Okay, thank you. When do you decide to use an external distractor?
Oh,
I never saw.
yeah,
I didn't
yeah,
see it in your presence.
So very good question. Very good question. So I'm very familiar, and I feel myself easy if I do use an external distractor. Because if the way when I advance, I still can manipulate a little bit the vectors, especially if I deal with a syndromic patient, with children. Even in some adults, I go for the external distractor, especially if I have asymmetries, if I have a role problem and I want to consider the role, or later on, I want to change the occlusion a little bit, the pitch a little bit. In these cases, I have problems using internal distractor where I hardly can play around in the vertical position, where I just can go in one vector. So
That was the problem when you have to desimpact.
Yeah. So generally asking, if I have the chance, I go for external distractor. But this is my personal choice. I have no evidence for this. Yeah.
We have one question. There's two questions, but what is the ideal period of consolidation? This is from Al-Taib Muhammad.
Yeah. So normally I wait near about 5 to 7 days, depend on the advancement I have and the gap what I have. And when I have done the osteotomy, I start even distract during the operation, that I have something like a small advancement. And then I start doing the distraction. Normally, in these cases where I want to do more than 7, something like 14 days. After 14 days, I let the retention at least 4 months, sometimes 6 months. This is my time. So I would say we keep the questions for later on and see after later on. Okay? Thank you.
Okay, thank you. Thank you. We'll meet you later on. Okay. So now is our next speaker, Dr. Alberto Haddad. Please.
Thank you very much, Nardi, for your kind presentation. Thank you also for the International Association for having this webinar series, which I think are very useful for everyone. Thanks also for the Education Committee, Dr. Gali, Dr. Rana, for having me here. And I will share my experience doing the other thing during orthognathic surgery. And I think that the best way to discuss after the presentations are to talk about one case. So I'm going to present one case. First of all, let me introduce myself. I'm Alberto Haddad. I came from Ramon y Cajal University Hospital in Madrid. I think all of you know Madrid, but if not, please come, and all of you are welcome to spend time with us. So my presentation is to have a little bit of debate about when we can do orthognathics or where we can do distraction osteogenesis. So let me introduce my case. This is a guy, an old male, 20-year-old male, when he came to our department with the diagnosis of Pierre-Robin syndrome. This is the follow-up that we have of the patient. And this boy underwent 2 distractions when he was a child. So after the first distraction, then try to move the mandible forward, and they do it just for sleep apnea purposes. And after that, they tried to make a second distraction when he was 9 years old. And after that second distraction, the patient underwent a left mandible fracture. So These pictures are the patient after the second distraction. He was 20 years old when he came to visit us to our department. And this is the occlusion that he had when we first met him. And after this, we have to give them a solution because he was worried not only about the aesthetics, but also about the functionality of the bite. So this is the X-ray that we have of the patient. We have a very, very hypoplastic mandible with the fracture in the left side. And this is the profile of our patient. So that was the problem that we have that we need to solve. And after seeing this X-ray, we do the normal planning that we do with all the orthognathic patients, and we do the movements without thinking of the syndrome. So what we need to achieve, and after that, how can we achieve that result? So this is the plan that we are trying to make. We are going to move a little bit the maxilla, not too much, because as much as we move the maxilla, the more that we have to move the mandible. So it's just a small movement of the upper maxilla with a counterclockwise rotation and the movement of the mandible, and also a genioplasty after the mandible. So this is the goal that we want to achieve with this patient. This is the CT scan that we made to the patient. There is also a lack of bone in the menton area after a resection of one included impact tooth. And we found here a lot of problems with the mandible. It's an hypoplastic mandible. We don't have a big bone. We also didn't have good angles of the mandible. So after seeing this case, we have, what will you do? So there are a lot of options. The simplest way is do nothing. Say the patient's okay, we don't have solution for your case. You are eating, you are having a nice life. So it's the easier way and finish the case. Everybody's happy and okay, but that's not our point. The second option is doing another distraction. He underwent 2. After the second, he had a fracture. So maybe it's not the best option. We can make a conventional orthognathic surgery without 3D planning, 3D printing, but maybe it's too complicated because of the mandible that we have. Or maybe we can do a personal specific implant orthognathic surgery. So nowadays we are in the era of personal implants, and that's why we moved to a personal specific implant surgery. All of you know that for making this planning, we need to have a CT scan. After that, as Professor Rana said, we have to make the design of the cuts that we are able or having to do after the surgery, and we have to design our costume plates in order to make it easier after the cut. So this is the planning that we are going to do. And why we are trusting this planning? This is a study that we've done in our department, and we published it in the European Journal of Craniomaxillofacial Surgery. And we measured the accuracy in between doing a conventional surgery or personal specific implant surgery. And we found in our results that the difference in measurements in between the conventional and the experimental group with personal specific implant are statistically significant. So that's why we feel comfortable with this technology, and that's why we plan this case in this way. So we also like to have a double check. People said that just planning with 3D printing, custom cutting guides and everything, you don't need the splints, but we always like to have the conventional way to check that our result is okay. So in this case, we also made a splint for the occlusion. And this is how we plan the case. We planned our case with the movements that we want to achieve in this kind of surgery. As I said before, we need a big advancement of the mandible, and the gaps that we are going to have are very big. So we also have that in mind. And once we design the cuts and the movements that we need to make, it's when we start to measuring everything. So we can measure everything in this type of technology. We can measure the gaps. We can measure all the movements that we are going to make. This is the maxilla. This is a case of maxilla first. Now you'll see. And these are the measurements of the mandible. We can see the nerve, where the nerve is in order to respect the nerve, and how wide is our gap in order to see if we have to do something else as you can see in our case. So these are the cutting guides that we designed. The first cutting guides that we've made were in one. Now we're doing in separate ways because the approach that we made for the maxilla is a small one, so we don't need to separate a lot. Just by slicing into pieces, it's more easier for us. And this is the cutting that we're going to make in the maxilla and the movement. And these are the specific implants that we're going to put in the maxilla. We can measure also the screws that we're going to use. So for us, it's very easy to use it. And this is the design of the cutting guides that we're going to use in the mandible, with the cuts in the mandible for the osteotomies in sagittal osteotomies in the mandible, and also the genioplasty that we're going to make. And these are the plates that we are going to manufacture in order just not only to get stabilization of the fragments, also to reconstruct the angle of the mandible. And also we design here a gap with 2 screws in order to put a bone graft for the healing of the gap that we have in this surgery, like you see here in the pictures. So these are the pictures of the surgery that we performed with a small approach in the maxilla. We put the cutting guides, as you can see. The surgery with cutting guides is very, very easy. There is a small place. We do the cut with a piezo because it's more thin and we are comfortable with that. After the cuts, the same holes that we put for the cutting guides are the same holes that we use for the plates. So as you can see, here are the holes. And after that, the positioning of the plates are really, really easy. It takes like 5 to 10 minutes to put the plates. This is the VSSO. We do an intraoral and extraoral approach because then we have to put the bone graft also. We preserve the fascial artery, as you can see now. And we use an iliac crest bone graft to put it in the gap that we have. This is the bone graft that we use, that we slice it into pieces. This is the cutting guide for the mandible. We also use the scars that have the patient for the approach, for the distraction that he had before. Here is the facial artery that we preserve, and this is the plate that the patient had for the anterior fracture when in the left side. And this is the way that we put the cutting guides, preserving the artery in order to have good blood supply for the fragments. This is the intraoral approach where we do the VSSO. And this is the positioning of the plates, also using the same holes that we've used for the cutting guides. And in the middle of the gap, we put our iliac crest bone graft with two screws as we planned before. This is the left side, same way that we've done before. And this is the genioplasty. The genioplasty also is very easy to make it with cutting guides. We use a small approach. We put the cutting guide, and after that we perform the genioplasty, and we put our plate in the position that we planned before. So this is all the material that we are using. As you see on the right side, the design of the plates were special in order to have those bone grafts in the mandible and to cover all the angle of the patient. This is the patient after the surgery. And this is the X-ray the day after the surgery. And we also have an intraoperative CT scan. These are the X-ray after the surgery also. And this is the intraoperative CT scan that we've done with the patient in order to see that everything that we perform match and that we don't have any problem with any fragment or the bone graft or wherever. This is the patient 6 months after the surgery. So he's very happy. Maybe we can do a little more of advancement, but that's why we, Dr. Ran, as said before, there are some limits for orthognathic surgery, and this patient underwent 2 distractions before. So that's the most advancement that we can achieve. This is also the guy. And this is the occlusion after the surgery. He's happy. His sleep apnea, it's okay. He is waiting for the new polysomnography because this case is 6 months ago. And that's it. I think it's a good case for debating, Nardi, Dr. Kasab, in order to see that there are some solutions that we can make not only with distractions, but also with orthognathic surgery. And this is a case when we perform the both techniques.
Thank you very much, Alberto. That's a real amazing case. I would like to ask you, did you consider during these many times that you distracted to do bone grafting, just not to distract, to use bone grafts as you did now?
Yes, well, this patient came to us after the distractions. But for me, if I were in the first distraction and I found that I need to do a bone graft, of course, I will do it the same way. Yes, but I think they tried to make him the first distraction when he was born in order to solve the apnea after the first day of living. The second one, I think they tried to move the mandible forward, but I think they make a small mistake because the move that they trying to achieve, I think it was a little bit more than the patient needs, and they don't make any graft or anything, and that's why the mandible fractured in the left side. So for us, when he came to us making another distraction, we were afraid of that. And the patient also, we spoke to him and he didn't want to start again with a distraction, with external distractions, the scars, everything. So we offered him this kind of surgery, and that's why we've done that.
Okay, and my second question is regarding the scars.
Mm-hmm.
I think you encountered, after so many procedures, when you did your procedure, you encountered a lot of scars.
Yeah.
Was it easy to move him forward, to do all the movements?
We found a little bit of complications when we do the movement of the mandible, and also to separate the fragments when we do the osteotomy. It was a little bit tricky, but after that we can do it because the bone was very thin and it was very cortical bone. So it was very difficult with the chisel to make the cut in the mandible because we were afraid to have a bad split in the mandible. So that's why we use the cutting guides. But we don't have any problems with the bone. We have a little bit problem with the skin here in the neck, because when we move a little bit forward the mandible and also with the genioplasty, sometimes the skin of the neck is too tight. And sometimes we don't do as much as we would because of that. But for us, we found those two tricky situations with that, and the rest was okay.
Okay, can I ask you some questions?
Of course.
Dr. Altaib Mohammed is asking do you remove the plates?
In Spain, we don't remove the plates. We just remove it if the patient have any complaining with the plates, like exposure of the plates or pain in the gingiva or something like that. But we don't remove it, like with all our, not only this case, but with all orthognathic cases, we don't remove it.
Okay, and then there is a question from Dr. Satnam Jolly. Why not you do C or L-shaped osteotomy as extra incision was used?
Yeah, we thought about that. It's a really good question. We thought about that, but we also want to reconstruct the angle of the mandible. And with an osteotomy and all the movement that we need to do, we thought that it would be more complicated. The first plan that we thought with this case is not making incisions in the skin, but when we find the gap that we have in order to bone graft that gap, that's why we performed that scar. We talked with the patient. We said to him, you will have a scar near the scars that you have for the distraction. So he was okay with that. And yeah, but we have that option also in mind.
Okay, now another question, Dr. Muhammad Adil Asim. Which instrumentation do you prefer for orthognathic surgery and distraction osteogenesis? Reciprocating saw or piezo surgery? I think you gave us during your lecture.
Yeah, it depends of the surgeon. Okay, I will say what I use. For me, for the mandible, always piezo surgery. I know that it's a little bit slower than the saw, but for me, I'm more precise and I feel more comfortable with piezo in the mandible. In maxilla, it depends on the case. If I see that the bone is very thick, I use the saw. If not, also I use the piezo. In this case, we use the piezo because with the cutting guides, the cut is more precise and you only have like 1 millimeter of cutting. And for the genioplasty, I always use the saw because it's faster.
Thank you. Okay, is Majid back with us? So we can go to the case that I prepare you for destruction. Majid? Not yet. Okay, I'll start presenting it and then we'll see. Okay. Where is the... So this is the case. She's a 21-year-old female with the chief complaint of protruded lower jaw. Of course, she started in the past orthodontic treatment and she's healthy. Now you can see her. Her maxilla is hypoplastic with a mandibular prognatism. Let me put it here. Okay. That's her. She has an asymmetry of the maxilla, as you see her. She has a 2 millimeter asymmetry on the left side. And she's you cannot see her central incisors. And when she smiles, you just see about 6 millimeters of the central incisors. Her chin, as you can see, I hope, is deviated to the left.
Mm-hmm.
That's her again. This is the E-line that you can see how hypoplastic she is. Again, you can see the asymmetry in the maxilla on the left side of 2 millimeters and her chin. Now she has an open bite of 5 millimeters and she has an overjet of minus 19 millimeters. As you remember, I'm sorry that Majid is not here with us, but Majid said he will prefer destruction when it's over 7 millimeters to advance. So this is a 19 millimeter case.
Mm-hmm.
That's her midline, which shows that the chin with the midline is deviated with the central incisors in the lower jaw. She has a hyperparabolic maxilla. And that's her condyles. You see that she has very long condyles.
Mm-hmm.
That's her. Okay, we can see the asymmetry here in the left side of the maxilla again. And that's her cephalometric analysis, which you can see that she is diagnosed as a hypoplastic maxilla with a mandibular prognatism.
Mm-hmm.
So this is the problem list. This is the bilateral condylar hyperplasia by Wolford type 1A. She has a retrognathic maxilla, a prognatic mandible. She has an angle and skeletal class 3, deviated lower midline 3 millimeter to the left, slight canting 2 millimeter to the left, negative overjet 19 millimeters, and she has some pain in her joints. This I didn't mention. Now, what do you think? What would you do?
For me, as I said Majid before, for me the limit for the maxilla more than 8, 9, even 10 millimeters, it's a little bit risky because of relapses. So the most that I'm comfortable with, it's around 8, and it depends of the case, 9, something like that. So this case that you show us, I think it's a good case for distraction, because move the mandible back, it's also an option, and you reduce the overjet and the overbite. But I think also, as Majid said, well, this case you have to put the mandible a little bit back. It's mandatory, I think, but we are trying not to do that nowadays because of sleep apnea, because of the skin in the neck, so a lot of things. So I think I will do here like a combined treatment with distraction of the maxilla, and after that making an orthognathic of the mandible, and the hypoplasia of the malar bone, maybe with an osteotomy of the zygoma or something like that, she will recover the hypoplasia that she has in both sides. That's the way that I think, seeing the pictures of the patients.
Okay, so you think that using distraction osteogenesis, this case is going to be more stable?
In my hands, I think that yes, because I don't measure it by 3D how the movements will are, because maybe if you put the mandible a little bit back and you move the maxilla, you could achieve, I don't know, maybe 8, 7, I don't know. If that is possible and you don't have to move the mandible too much back, it's one option. But looking at the X-ray and looking at the pictures, I think that you must take the mandible a little bit too much back to achieve the advancement that you need. So maybe you have to make a distraction of the maxilla. That's my opinion. you can.
Of course. Are there any complications that you fear during distraction?
Well, this lady's, I think it was 21, right, or something like that. She's young.
Yeah.
I think, yeah, with a good rhythm of distraction, not too fast, 21-year-old young woman without any other clinical illnesses or complications or whatever, the stability must be good. If that case would be in a 40 years old woman or something like that, maybe it will be more complicated to have a good stability of the fragments. But I think that when you treat young patients, this kind of surgeries have good results after the distractions. There is like no an age where you said go it for distraction, no going for distraction. I think it's like the experience of every center, but I suppose that with 21 years that will be a good stability.
So there was a question from the people in the audience about how do you stabilize the occlusion?
Well, in normal case of orthognathic surgery, I put elastics. I never put wires. I just put elastics and soft elastics, not too much tight, for 2 weeks, something like that, just in order to guide the occlusion, not to keep them with the bite closed. So around 2 weeks after that, orthodontics made the treatment. They changed the elastics and everything, but for maybe 10 days, 2 weeks, something like that in a normal case. In the case that I presented today, it was with elastics around, I remember, 2 weeks and a half, something like that, because also it's important to start the patient to do rehabilitation and opening of the mouth for the condyles. So that's why we don't like to keep them a lot of time with an bimaxillary closed. So yeah, around those times.
But during destruction, do you do methods like that, like molding, the regenerate?
Yeah, of course, of course.
Mhm.
Well, now it's Majid here, so he can also.
Majid, you're here? I don't see
Yeah.
him.
I see
Oh yeah,
him.
here I
Yeah.
am. Here I am.
Okay, okay.
Yes.
So I'll go back just to show you very fast. Oh, why? How do I go back here? Oh, I see. Okay, so I'll show you very fast what we're talking about. Okay. This is a young woman, 21, female, with maxillary hypoplasia and mandibular prognatism. That's her. She has some asymmetries. She has a chin asymmetry, and she has in the maxilla an asymmetry of 2 millimeters. Now her open bite is 5 millimeters, and her overjet is minus 19. That's the asymmetry that she has in the lower jaw. You see the line in the lower jaw is the same with the chin. It's aligned with the chin. Again, the asymmetries, and that's the cephalometric X-ray, which you see the overjet of minus 19. Now you say that this is what we were discussing, that you said that over 7 millimeters, you prefer destruction.
Yes. So thanks for this
How
case.
would you manage this case?
So it's a perfect way to show. So especially in this case, because she has a long face syndrome, I will rather plan to close the mandible, to see if I can impact the maxilla and calculate via closing the mandible, like virtually, if I have less to advance. If it's a little bit more than 7 millimeters, yes, like I told you already before, I will perform a LIFO 1 in a first step and do in LIFO 1 a distraction. I will go for an internal distractor. I will take the wisdom teeth out in this part. And after that, I will go for maybe only a monomax, because once I have distracted that, I only need to look a little bit on the midline, and that will come from the maxilla, and I can vertically close the mandible and solve it like that. That would be my plan, only looking to the lateral ceph and the clinical picture.
Thank you, Majid. Now I'll show you just very fast what we did. So this is the problem list. And these were my questions, but we did a 3D design of ProPlan CMF with combeam and surgical glides and plates. The maxilla was advanced 10 millimeter with bone grafts from the mandible in the anterior and posterior region, and the left canting, of course, of the maxilla was addressed, and the mandible setback of 11 millimeters with a BSSO. So that's, of course, the planning that we all know, advancing the maxilla and putting the mandible. And this is her surgery, again, with the guides, with the screws that you mentioned, that we have the place of the screws. And this is the PSI, the plate. And the BSSO with the bone grafts in the anterior region and posterior region from the mandible. That's her with elastics, and that's her before and after, pre-op and post-op, and that's her.
Yeah, congratulations for the really
No,
nice.
I know, congratulations. Thank you very much, but
Congratulations.
it's
yeah.
always my question, should we distract or not?
I think I'm a hardliner. If it has come to mandible setback. Yes, in terms of
That's what Alberto mentioned also. That
Yeah,
he
I
hasn't
said the
like
same.
these
I said the same.
setbacks.
Yeah, because I do the midline correction, and sometime with a small asymmetry, small shift I will do. But so in Caucasian people, I never ever will do like that large amount. So only to correct the midline. I have some patients like Asian people, like China, Korea. So they really have a severe class 3. So even in that cases, I don't do a large setback. But again, especially on female patient, you need to put a pistol on my head to force me to do a mandible setback. But of course, many ways goes to Rome, and I can congratulate to you really to a nice result. But I think I'm again now when I see your post-op result again, yes, very nice. Again, I will say I will solve that only with a maxilla. I will distract first, and after distraction, I only close it a little bit. I will shorten the whole long face back to close the mandible. Because if I vertically close the mandible a little bit, I think maybe it could work also.
Okay. Now, thank you. Can I ask you, there was a special question for you, Majid, from Dr. Adrian Sugar. Majid, if you have a genuine case of nasomaxillary hypoplasia, whether syndromic as other or as in Binder syndrome or non-syndromic, why do you not do a Lefort 2 osteotomy, as this has nothing to do with the malar zygomatic bones?
So thanks for the question, Adrian. Of course, in these cases, it's indicated to go like this. But in my clinical practice, these cases are so rare, so I have never need to deal with that. But theoretically, yes, it makes sense to do it.
Okay, we have another question, which are you removing maxillary third molars before surgery or at the time of surgery?
Depends, once again, if I do an advancement.
No, if you are removing the maxillary third molars before surgery or at the time of surgery, and I believe it's related also to the maxilla and mandible.
Yeah, I remove it before. Yeah, I remove it before, and 4 months before surgery, something like that. I remove in the mandible. In the maxilla, I don't care. If
me also, same concept.
Yeah,
I agree the same. We do it the same. How often you use bone grafts in maxillary advancement and which ones? I think this was related to my case. So generally, if we need to advance more than 7 millimeters, as Majid said, then we use bone grafts as stoppers in the posterior region and in the anterior region. And this is taking from the mandible, because as in this case, if we did a BSSO, then you have in the proximal segment, you can use from your osteotomy the bone, and you can also use bone from the chin. So this is divided to these portions. Okay. Would you consider scintigraphy SPECT CT case in a case like this before you proceed with surgery? I think it's again for me. That's Dr. Gregory Tour. We always evaluate these cases, especially with asymmetries, but the SPECT CT, it's not a clear-cut choice. You need to follow these patients, and you need to know exactly what happened. Sometimes we take their occlusion, we mark their occlusion, and we keep it. And when they come after half a year, we keep them for half a year, then we try to see if the occlusion gets back or they still grow. So thank you for the question. That's a great question, but they really need to be evaluated. Okay, we have an anonymous attendee. Question for Dr. Amjid, please. For distraction osteogenesis of mandible, do you perform bicortical osteotomy with piezo saw instrument or just perform lateral corticotomy followed by lingual osteotomy with osteotomes?
Thanks for the question. Of course, so I'm not a big fan of piezo. So therefore, I like the Lindemann coming from Düsseldorf here. So the Lindemann burr is my special tool for the mandible.
Okay. Any advices or tricks in patients with the alveolar cleft with cleft palate? Can I answer to this question one case? One thing, I choose, I'm asking you, Dr. Mohammed, to come to San Diego, because there I choose a case like that with cleft surgery. And now, please, Alberto or Majid, can you refer to the question?
Thank you, Mohammed, for the question. Yeah, I think that you have to keep in mind two things. One is the advancement that you're going to make, because you can have problems that you don't have before, like velopharyngeal insufficiency or something like that. So it's important not to move too forward because of the soft tissues. And also, if you're going to do a segmentary Lefort, we used to make the segmentation in the cleft, not in other pieces of the maxilla, in order not to compromise the vascularization of the soft tissues. That's the two things that I think that you can take in your account when you're doing cleft patients and orthognathic surgery.
Majid, you want to tell us some tricks?
Yes, I agree with that. I agree with that. Sometimes we need to think about, and even in some cases where the premaxilla or the anterior part is floating, even in that case, sometimes I go for like a bone grafting and put some plates in it and stabilize that first and wait until for further treatment.
Mm-hmm.
Any more questions? Okay, I think it was amazing. I'm happy that we did that. And it's not easy to deal with these things because there's still controversies, as we know. And thank you very, very much for both of you. That was very interesting for me. Thank you.
No, thanks to you for moderating this wonderful session. And I want to thank really all the participants coming. And I could see that meanwhile we had something like 68, which is amazing. And dear participants, we are going to keep the series every third Thursday at the same time. So please follow us in that series. Thank you very much.
Also, nothing more to say. Thank you, Dr. Kassab. Thank you, Majid. Thank you all the staff and all the attendants. It was a really good webinar, and hope to see you all together in the next one.
Yeah. And if you can stay on the line to have a group picture later. Thank you.
Okay.
Thank you, doctors. For today's participants, today's session has been recorded and will be available on demand soon at learning.ioms.org. On behalf of IOMS, thank you to our presenters, moderator, and all our participants. Wherever you are, have a good morning, afternoon, good evening, and good night.
Thank you.